So these are the drug studies that we have right now. I've kind of grouped them by medication, and then I'm going to review them in a little more detail. We've got fluvoxamine, fluoxetine, sertraline are the three medications that have really shown good efficacy and low to minimal side effect or no side effects. The paroxetine has shown more significant side effects. We'll talk about that. And so it's not recommended as a first-line SSRI for that reason. Some people actually will not use it at all. Concerns about it has a higher risk for suicidal ideation. Some people feel that's more of a relative risk. But certainly in my clinic, that's not a medication of choice. I will use that much later. So here are some of the studies for selective mutism. We have fluoxetine. Black and Udi did the study some years ago. What's interesting about this study is the fluoxetine did beat out placebo in this population. You can see some young children were in this study for social phobia and selective mutism. But even with the medication, these children still remained impaired at the end of the study. So that's symptomatic improvement, but they remained impaired. Medication alone was not enough really to treat this population. Also with selective mutism, fluoxetine and sertraline open trials have been done as well. So I've given you some of that information and have been successful with, as I said, maybe showing in young children some more side effects though with behavioral disinhibition as something to watch for. Then we have the RUP study, which is a very large study versus the last one, which was a small one. This was one of the first large multi-site studies, and this work group really got things going in childhood anxiety. You see they looked at separation anxiety, GAD, and social phobia. That's what most of these large studies do now, look at those three disorders. Again, the fluvoxamine beat out placebo, okay? And this was after a 3-week failed psychotherapy trial that they gave the medication. Those with severe illness or the presence of social phobia in this population had poorer outcomes. And then those are some of the side effects. They were not significant. So 94% of the subjects who initially responded continued on fluvoxamine, remained well. 71% who are non-responders did well on fluoxetine, generic Prozac. And then 56% of non-responders initially also to the placebo, then responded to fluvoxamine. We've got another study on generalized anxiety by Dr. Rin, and in this study, because this was a fixed dose study that only went up to 50 milligrams, which again, that's not a very high dose, but they had at least some clinical improvement in 90% versus 10% on the placebo. 2 of the 11 patients had marked improvement, and a remission rate of 18%. Now this is a fairly low remission rate, but again, you're looking at, she only went up to 50 milligrams. Okay, and there were no significant side effects, meaning people having to drop out, but I listed some of the side effects that did exist greater than placebo. With the fluoxetine study by Burmar, again in this study he started at 10 milligrams, only went up to 20. So again, not getting up to a high dose was something that he felt may have influenced his results, but again, fluoxetine certainly beat out placebo, and we had significantly improved global functioning. Now, one of the things he found in this study and is later talked about is that if you're not getting any results at a month or not getting significant results at a month, go ahead and increase the medicine. Don't wait 2 months. Go ahead and increase at 1 month to the next dose. And this is even with fluoxetine, which has a long half-life. They did have 5 non-completers due to behavioral inhibition and excitement and giddiness that was significant in this study. Again, he had poor outcome when there was a positive family history of anxiety that influenced the results. This is a study that compared social anxiety treatment. Deb Beidel has a treatment that allows you to have the kids in a group with other kids who don't have social anxiety in addition to the regular CBT work. And she found that placebo and the social skills group treatment that she has, they both beat out placebo for social anxiety disorder, but they had some more gains in social competence with her CBT. Okay, this was not a combined study, so we don't know how they would have done on both. Then we have the paroxetine study. Again, this is multi-site, very large. You can see that these kids were pushed to a fairly high dose, 50 milligrams. If they needed it, it was flexible dosing, but they had significant adverse effects: insomnia, decreased appetite, vomiting, and in addition to that, some activation was more prominent in younger children. So again, we don't necessarily use this medication first line. I've mentioned some of the other cautions with paroxetine. Also, the European Medicines Agency has recommended that it not be prescribed to children. This is, again, in the European countries. But they felt strongly that the side effect profile, that it has a short half-life, more likely to see increased suicidal risk in these patients, treatment emergent. So again, we really have to think cautiously about using this. If there's a family history that's strong, if a child is not responding to other SSRIs, certainly you need to consider it, but you're going to have to monitor it closely. Then we have venlafaxine. When we have found that the SSRIs are not effective, we want to try several SSRIs. I have patients, I try every single SSRI. Sometimes that's what I have to do to find the one that's effective for them. I'd rather they be on an SSRI than any other medicine because they have shown efficacy more than any other medicine. Then I'll move to venlafaxine. Again, there were two large trials. One of them was equivocal, but the other one showed good results. They combined those studies, and together they showed that combined response rate that I've got at the bottom. The other trial was smaller, the social phobia trial I've mentioned there. And so, again, we've got a few studies with venlafaxine. At least we've got shown some efficacy. I think it's a good second line. The challenge with venlafaxine is we also have a higher rate of suicide. We also have a number of side effects I've mentioned here. You're going to have to monitor cardiac side effects with venlafaxine. So we've got to do a higher level of monitoring. This is why it's not a first-line medication and should not be used first-line.
You mean higher rate of suicidality?
Suicidality, right. I'm sorry, not suicide, just suicidal ideation risk. I'm glad you clarified that. Thank you. Okay, then we've got other medications that just don't have a lot of efficacy. We've got the tricyclic antidepressants, and I've shown there that none of these have really shown efficacy in the studies that have been done. These are all fairly old studies, and so it's important to be aware that these are older studies. There was a more recent study with the school refusal population, and that study was done by Gail Bernstein, who does very good research, and she was able to show that the combination of imipramine and CBT beat out placebo and CBT for these severe patients with anxiety and depression who are school refusing. And she found that in follow-up that for those patients that when they were followed up, they had to maintain both treatments over many years in order to continue to not be school refusing. So these are severe patients, more likely what you see in the community. At that time, they didn't have the SSRIs available, so that's why that study was done that way. Clomipramine is more in the OCD world, but something that we can certainly try. I've had some patients who respond to clomipramine who haven't responded to the other SSRIs. I think it's worth trying, but you're going to have to do TCA monitoring. So again, has some added risk, but again, may benefit some of our patients. Buspirone, we have no evidence really for the most part in the literature, or very little evidence. Again, it's worth trying. One thing we do know is we need to use lower doses than we do in adults. Benzodiazepines, again, we've had some studies. None of them have really shown efficacy, but often we need to use it as a medicine that is short. We can use it short-term initially, and then we need to add the SSRIs once they take effect. We don't want people on benzos long-term. What I've done is I've made a slide of the, I've kind of listed all the different potential side effects. One of the things we need to consider is in teens who are pregnant or breastfeeding. We don't want them on a benzodiazepine. We've got a lot of side effects that can affect your cognitive well-being. It's hard to learn with the side effects that you have, so it's hard for children to be in the school setting. I've given you the mild withdrawal and severe withdrawal symptoms. And these are the studies. They're all equivocal. Okay? This is something that Dr. Strom actually has a study and is part of a study that's a national study, and several sites are participating using guanfacine for kids with anxiety disorders. this becomes important when we have comorbidities such as bipolar disorder. And the SSRIs and other medications I've talked about aren't an option for these patients or lead them to have hypomania or mania. I've had very good results with guanfacine combined with other things as well. Okay. Panic disorder, we don't have any placebo-controlled studies. So I've given you some studies that have shown some efficacy for a whole range of SSRIs, as well as for using short-term benzodiazepine as your starting treatment, and then until the SSRI takes effect. But none of these are, again, placebo-controlled. I've kind of summarized the meds for you here, and the dosing ranges. And you don't have this slide, but you will. I'll get that to everybody. I've actually covered most of these things, but I wanted to emphasize what I mentioned. Routine screening is important. We want to do a good assessment. We want to identify anxiety disorders early. We want to treat comorbid conditions if that's what's most relevant. We need to treat often both at the same time. For mild to moderate, we can start with CBT. Then we can add the medications when either CBT isn't enough or the child is so severely impaired that trying CBT will actually lead them to feel worse. Want to maximize dosing, but we also want to start at low enough dosing in young children that we're not leading to side effects before they get a chance to experience actually the good effects of these meds. We want to check for family history also of anxiety disorders in our choices. I mentioned to you that Paxil is not recommended as a first-line medication, okay, relative to the other SSRIs. Level 2, we can try venlafaxine. We've got to monitor, though, and maybe we can add that in here. We're going to have to monitor cardiac side effects. We're going to have to be cautious about increased suicidal ideation. Level 3, all the other medications I mentioned, we can use adjunctively or alone. We just don't have a lot of evidence there. Okay? But monotherapy with a benzodiazepine first line or long term is not recommended. Okay, so I guess that's one thing I want to make sure that we think about. So I put that on my red flags too. And so, again, starting a medication trial without discussion of CBT at all, I would not recommend. Using paroxetine as first line, I would not recommend. Using benzos as a single agent long term without trials of SSRIs or venlafaxine, I would not recommend. Committing to long-term pharmacotherapy prior to maximizing any one initial medicine, using polypharmacy without really maximizing trials, not a good thing. And then starting young children at a high dose is not recommended. They need to be started at lower doses than adolescents. And then finally, that in children with comorbid anxiety and bipolar, we need to initiate SSRI treatment. We should not initiate SSRI treatment first, really need to treat the bipolar disorder first. We'll be talking more about that later.